answering the questions and all. So welcome everyone, and thank you all for having spared your time to join for this consultation. So as you would know that we had rolled out a consultation paper on value-based care and value-based incentives on the 22nd of June, and we gave a month's time for the stakeholders to provide us with feedback and comments. So it is in that light itself that we are trying to have this consultation, wherein we have this opportunity where we can present our thoughts and we can hear from you about your feedback. So before I make the presentation, I'll invite my colleague, Dr. Sudha Chandrasekhar, who's an executive director at the National Health Authority, to give the opening remarks.
Thanks, Dr. Shankar. A very warm welcome to all the participants from the private sector. I think this is a very important initiative for the PMJAY scheme and the National Health Authority, because as we are stepping in to the close of 4th year, I think it's important that we are moving ahead from the quantity or just providing access to services to see how we can improve the quality of care that the beneficiaries are receiving. So in that sense, the shift is kind of imminent. And what we have tried to do is also use the different country experiences and make sure that we are incorporating those valuable experiences in our scheme, because we cannot be a very static kind of an implementation agency. And with a scheme of this scale, we need to be quite innovative and keep ourselves dynamic to the requirement of the emerging needs of the implementation. So in that sense, what we have also tried to do is see how we can move from just an accreditation based quality kind of an incentive to start with, to be moving to a value based incentive. So we do understand that value based care is a much bigger concept than a value based incentive, but to that extent, I think this would be a good step to move towards that, so that we are able to incentivize the performance and outcomes of the patient care. So this gives some kind of interim movement in our march towards a much broader value-based care concept. We do understand that these kind of reforms, which are quite extensive, and we need to ensure that we have a broad-based consultation with all the stakeholders. So in the morning, we had consultation with all our state health agencies and the public hospitals. So more than 450 participants had participated in the morning session. So in that sense, that's a rich information, especially because this feedback is very important for the operational feasibility, because coming up with concepts and guidelines is different, but ensuring that it is implemented well, we need to do this preliminary and the preparatory exercises, and these consultations give a much feedback for us to revise, refine, and improvise the implementation. And we are looking at a very multidisciplinary approach for this kind of an incentivization. And we do understand that we cannot have all the indicators, but these would be used as tracer indicators of how we can assess the performance of the hospital. I'm sure Dr. Shankar will be giving full details in the presentation, but we really need your feedback, and I hope this will be a good interactive session, and we learn from each other and improvise this concept much more, and that will help in better implementation. So thank you, and over to you, Dr. Shankar.
Thank you very much, Dr. Sudha. So we have our Deputy CEO, Dr. Vipul Agarwal, who will also be joining soon. But in the interest of time, we'll just move over and we'll hear his thoughts once he's joined this particular meeting. So just to say that we are very much committed to having a much more inclusive and participatory process of developing policies. And it is in this line that we have initiated these consultations. For those of you who participated in the last consultation, which we had on provider payment methods and pricing policy, I'm happy to share that we made a note of all the comments that we received and a detailed reply to all the queries and suggestions that we received and feedbacks that we had obtained. have all been posted on the NHA website today. So for those of you who had submitted any feedback on the other earlier consultation paper, can refer to the replies that we have submitted today. And we'll shortly be coming out with a policy document on the provider payment methods and pricing based on that. And it is in that line that we want to move forward and further make improvisations in our entire approach and the frameworks that we use. And we have come up with this concept of value-based care and incentives. And I'll try over the next 35 or 40 minutes to run you over through with giving you some insights into the consultation paper that we have hosted. And this has two parts. The section 1 of the consultation paper talks about value-based care in general, talks about the basic concepts, the need, and some applications of that within the PMJAY that we currently have introduced, and also highlighting that some of the areas that where we in future want to move towards that road of value-based care. So what we talk about in this first section is an illustration of the shift towards value-based care, where we have argued that most of the traditional methods of payment to hospitals who provide healthcare have largely focused on quantity of healthcare services delivered, whether it is fee-for-service or case-based payment methods. Largely, the total volume of payment that a particular hospital receives is directly proportional to the volume of services that he or she has delivered. In fact, there are some payment methods like capitation, for that matter, which do not even take into consideration even the quantity of services that are delivered. However, the case-based payment methods that we use as part of our PMJAY reimbursements, it basically relies on the number of surgeries done, the number of medical packages booked, etc., and pays the hospitals according to that. However, we want to shift towards a more value-based methodology of determining how much a provider receives as remuneration of the services delivered. And these are directly related to the quality of care, besides just the quantity, by the quality of care that is delivered, and which is objectively measured in terms of some quantifiable gains in terms of the health outcomes that the ultimate beneficiary of our scheme is able to achieve. It is quite obvious, but just to reiterate that why is it that there is an importance of quality in the overall care delivery? There has been a recent very strong evidence to link the quality of care with the extent of mortality that happens in low and middle income countries. And based on this 2018 Lancet Commission on quality that was set up, it reported that of all the amenable, or what you can say preventable mortality that happens in healthcare within the low and middle income countries, 40% of that could be attributable to reasons that can be explained by lack of availability of services or lack of access. Whereas the remaining 60% of this avertable mortality or amenable mortality is because of poor quality care, which means that a large unmet need for mortality is actually attributable to poor quality care. And within our PMJAY ecosystem, we try and make a concerted effort towards trying to address this issue of quality through a variety of different mechanisms. So we have on one hand, we have been trying to engage with the empaneled hospitals by creation of these quality cells within the state health agencies that work on a more regular basis to undertake something similar to a supportive supervision, to nudge the hospitals towards better processes, better infrastructure, and better outcomes of clinical care delivery. And as part of that, we have also drafted an audit checklist, which the functionaries of the quality cells make use of when they visit the hospitals and try and see that different aspects of infrastructure, input, processes, outcomes, etc., SOPs, etc., are they in place or not. Besides that, we have certain financial nudges also, whereby we have created some system of certification of the empaneled hospitals. So we have PMJAY bronze, silver, and gold certificate hospitals, where silver and gold are in sync with the NABH entry and full accreditation. whereas the bronze certification is based on a set of quality standards that have been jointly determined by the NHA and the Quality Council of India. And the public sector NQAS hospitals are also eligible to are also comparable to the gold certification. And each of these certified hospitals receive an incentive that is over and above the current prescribed base rate for a given package. Other than that, there are other non-financial nudges to improve quality as well. For example, recognizing the good performing or top performing hospitals during certain days of national importance, recognizing and building in the discourse on quality as part of the different celebration of international days that we perform. And more recently, the AB PMJAY NABH Center of Excellence that we have, standards that we have developed in partnership with the NABH for specifically targeting at super specialty care. And more recently, we have also been engaging with the Quality Council of India and the NABH to develop standards for daycare centers and standalone centers which are delivering care for dialysis. And we are also trying to incorporate some benchmarks or criteria for empaneling standalone centers which deliver chemotherapy services as well. So these are the kind of initiatives that currently are in place to improve the quality of care. And as I mentioned, that there are financial incentives that are linked to accreditation levels. So we have 5%, 10%, and 15% incentive over and above the price of the package that are that the hospitals with these accreditations are entitled to, whether these are bronze, silver, or gold certified hospital. Moving forward, the concept of value-based care basically tries to hit at 5 different points. The first, it tries to overall improve the quality of care. This enables ensuring better health outcomes for the patients who are getting treated. And there is a kind of enabling environment that is built within the facilities whereby providers engage with the patients in order to improve their healthcare. There's an effort towards trying to standardize the processes that are involved in delivery of healthcare services, developing standard operating procedures, development of guidelines, etc. And all of this ultimately, from a payer's perspective, aims at achieving better care efficiencies, which means that you want to have the best value for the money that is being spent and maximize the amount of health that you gain with the amount of investments that are being done. And looking at the connotation of value within value-based care, this connotation varies according to the kind of perspective that you choose. So from a personal perspective, it's much more at an individual level where patients look at value in terms of the most appropriate care that is delivered to them in a manner that gives them the highest satisfaction of care. However, if you look at from more of a technical lens, then the connotation of value much more relies on achieving the best possible outcomes given the amount of money that we are spending. And we're not only just looking at the technical efficiency from the point of view of having services that are more cost effective, but also from an allocative efficiency point of view and from the point of view of that the overall distribution, from a distributional point of view, the resources are spent in a way that it ensures that the ones who are the needy and the ones who are the most vulnerable get the benefit of this public financing. So which means that we have the distribution of resources that are much more equitable across regions, across patient groups, etc. And finally, if all of this happens, then at the societal level, the patients or the beneficiaries who enjoy a better health are able to contribute better in terms of social participation and contribute back to the society. So as you can see that there can be different connotations of value within value-based care. And given all of this background, this is the last slide that tries to basically summarize the different aspects or interventions or programmatic facets that are incorporated within PMJAY ecosystem in order to further enhance value-based care. So I'll try and run through in a clockwise manner, starting from the integration of care delivery system. So इंटीग्रेशन ऑफ केयर डिलीवरी में, सो आई गॉट अ मैसेज दैट आई शुड ट्राई एंड मिक्स अप, सो मैं थोड़ा थोड़ा हिंदी और इंग्लिश दोनों को अप्लाई करूंगा. सो इंटीग्रेशन ऑफ केयर डिलीवरी में हमारा पर्पस ये है कि वी वांट टू हैव अ कंटिन्यूम ऑफ केयर अप्रोच. कंटिन्यूम ऑफ केयर अप्रोच का मतलब ये है कि हम प्राइमरी, सेकेंडरी और टर्शरी इन तीनों चीजों में कहीं ना कहीं कंटिन्यूम एस्टैब्लिश करना चाहते हैं. बिकॉज वी रिकग्नाइज कि अगर पेशेंट एक बार जब एक सर्जरी करा के टर्शरी केयर हॉस्पिटल से डिस्चार्ज होकर अपने घर आता है, तो he requires some follow up care there as well, some kind of care at the home setting, some kind of contact with the healthcare services. Similarly, identify karna ki who are all responsible, who all need secondary and tertiary care. Again, this becomes more easier अगर हम इसको प्राइमरी केयर के साथ लिंक कर दें, so that there is an early detection rather than patients getting into a more severe health state and then they seek secondary or tertiary care. हम ये भी चाहते हैं कि हम early detection को promote करें, and that can only happen through continuum of care where there is an integration between primary, secondary and tertiary care. And इसमें we are trying to work at both IT integrations also, या जो हमारी functional process level integration also, और कहीं ना कहीं जो पर्सनल जो काम कर रहे हैं टीच ऑफ द 3 डिफरेंट लेवल्स, उनकी भी सेंसिटाइजेशन की वी आर ट्राइंग टू अटेम्प्ट दैट. अदर देन दैट, हमारे नए जो हेल्थ बेनिफिट पैकेज हमने रिलीज किया इन 2020 अप्रैल दिस ईयर इटसेल्फ, उसमें हमने फॉलो अप पैकेजेस इनकॉर्पोरेट किए हैं, व्हिच मींस दैट इफ एंड स्पेसिफिकली फॉर कार्डियोलॉजी, कार्डियोथोरेसिक सर्जरी, यूरोलॉजी, वेयर अगर आप कुछ प्रोसीजर्स कराते हैं तो यू डू नॉट एंड द केयर एट द पॉइंट ऑफ डिस्चार्ज ऑफ द पेशेंट, बट इसके बाद भी फॉलो अप केयर की जरूरत पड़ती है, सो दैट द पेशेंट कंटिन्यूज टू रिमेन हैविंग गुड आउटकम्स. नहीं तो ही विल डेवलप कॉम्प्लिकेशन, और कॉम्प्लिकेशन हो जाएगी तो फिर से हॉस्पिटलाइजेशन होगा, एडमिशन होगा, फिर उसका खर्चा होगा. तो फ्रॉम एन एफिशिएंसी पॉइंट ऑफ व्यू आल्सो इट मेक्स सेंस कि अगर हमारे पास फॉलो अप पैकेजेस अवेलेबल हो जिसमें अप्रोप्रिएट डायग्नोस्टिक और मेडिकेशन सपोर्ट अवेलेबल हो. Similarly, for certain specialties like mental health, we have added daycare packages, जिसमें we know that you don't need a hospitalization, but there is a detailed assessment, psychometric, psychoanalysis, और इसमें therapeutic, pharmacological and non-pharmacological treatment भी चाहिए होता है. And then we have quality cells and checklist, जिसकी मैं बात कर चुका हूँ. The second is we are trying to do expand the geographic reach. इसको करने के लिए हमने दो वेज में हम इसको टारगेट कर रहे हैं. एक, हमने जो HPP अभी रिसेंट इंट्रोड्यूस किया है 2022 में, उसमें हमने डिफरेंशियल प्राइसिंग किया है. दैट मींस हॉस्पिटल्स दैट आर लोकेटेड इन डिफरेंट सिटीज, जैसे कि टियर 1 हो, टियर 2 हो या टियर 3 हो, उनमें डिफरेंट लेवल्स ऑफ पेमेंट मिलेगी, सो दैट हॉस्पिटल्स का जितना औसतन खर्चा होता है अलग अलग शहरों में, उनको लगभग उस मापदंड के हिसाब से हम पेमेंट्स प्रोवाइड करें. दूसरा, व्हाट वी हैव डन इज दैट, ये एक पहले से प्रोविजन थी कि जो वी ऑल्सो नो दैट हार्ड टू रीच एरियाज, जो वल्नरेबल डिस्ट्रिक्ट्स हैं, जो एस्पिरेशनल डिस्ट्रिक्ट्स हैं, वहां पर nobody wants to go and work, and वहां पे उसी चीज के लिए खर्चे ज्यादा होते हैं. तो we want to ensure कि वहां पर there is an incentive over and above the price that is set. So ये पहले से प्रोविजन है कि 10% additional aspirational districts का incentive है प्राइस में. IT is a very important construct because the whole business of monitoring and managing the operations largely relies on the IT platform. तो हमारा IT platform पहले से ही हमारा ट्रांजैक्शन मैनेजमेंट सिस्टम का पेपरलेस प्रिंसिपल है, और इंट्रोडक्शन ऑफ ये जो हमारा डिजिटल हेल्थ मिशन है, इसके इंट्रोडक्शन से दिस हैज बिकम इवन मोर अप्रोप्रिएट. सो मूविंग फॉरवर्ड, वी आर आल्सो गोइंग टुवर्ड्स परफॉर्मेंस बेस्ड पेमेंट सिस्टम्स, जिसमें कि हमारे दो मेजर इनिशिएटिव्स हैं रिसेंट टाइम्स में. एक, हमने DRG बेस्ड पेमेंट सिस्टम का एक पायलट इंट्रोड्यूस किया है. इसमें what हमारी जो इंटेंशन है वो ये है कि that the payment that a hospital receives is something that is not just a fixed payment for a given package or a disease, but इसको हम अगर हम इसको इस depending on the complication, depending on comorbidity and depending on the level of the severity of the case, हम एक पेशेंट एक ही डिजीज कंडीशन का हो उसको डिफरेंटली पे कर सकते हैं टू द हॉस्पिटल, डिपेंडिंग ऑन कि कितना सीवियर पेशेंट था जिसका ट्रीटमेंट हुआ. एंड जो मैं नेक्स्ट सेक्शन में बताने जाऊंगा, विच इज अबाउट वैल्यू बेस्ड इंसेंटिव, इसको मैं नेक्स्ट सेक्शन में कवर करूंगा. अनदर मेजर initiative जो हमने किया है within this broader domain of value-based care is to have a systematic measurement of costs and outcomes. Now this is very important क्योंकि we want to ensure that we maximize on the efficiency of the scheme. उसके लिए costs and outcomes दोनों को measure करना बहुत जरूरी है किसी भी नई treatment के लिए, किसी भी नई drug के लिए. So in order to do that, we have set up this HFTA unit, which is Health Financing and Technology Assessment Unit. And we have set up a system whereby submissions can be made for inclusions into the health benefit package, and they are appraised based on standardized processes and evaluation metrics, and based on that एक decision लिया जा सके उसके ऊपर. हम अपने एक कॉल सेंटर को भी और स्ट्रेंथन कर रहे हैं. ऑलरेडी मैकेनिज्म्स आर इन प्लेस टू असेस यूजर एक्सपीरियंस, बट इसको जब ये वैल्यू बेस्ड इंसेंटिव्स का मैं बताऊंगा तो उससे आपको पता चलेगा कि हाउ call center will become a very important mechanism to generate certain information that will be used for value-based incentives. And similarly, ultimately, we are trying to organize this entire care around conditions rather than specific services को देखना या specific facilities को देखना. So at the end of this first chapter, we have tried to outline certain questions for stakeholders to provide their opinion, views, and feedback. And these questions are mainly to elicit what your opinion is about the different elements that are required to capture the value within this value-based care proposition. And then हमने framework present किया है उसके ऊपर आपके comments invite किए हैं to tell us that how appropriate it is. Do you think that there should be more aspects that should be added to the overall framework? And जो next section में मैं value-based incentives के बारे में बताऊंगा, is that something that seems to be appropriate? So this is the first section of our consultation paper, and the second section of the consultation paper, it mainly talks about the strategy for introducing the value-based incentives under the PMJAY. And इस section में what we have tried to articulate is that what should be the methodology of determining value-based incentives, what should be those indicators, how should we collect the information or data to generate those indicators, and then उसकी computation कैसे किया जाए so that we determine an appropriate incentive level. So this is all that is described in section 2. So the current incentive system that operates within the scheme, it basically provides incentives to hospitals either based on some kind of accreditation levels like an entry level or a full accreditation for NABH or an NQAS, or a kind of a bronze certification, quality certification under PMJAY. The two other incentives that exist are related to the place where the hospital is located, and it incentivizes hospitals that are in aspirational districts or metro cities. One because cost of care is higher here, and the other because we want to ensure that there is greater investment in these districts. And then we have also an additional incentive here, which is for teaching hospitals. And this is 10% over and above the base package. However, it is important to recognize that as states move and migrate towards HPP 2022 and we introduce a differential payment system, the two incentives of metro city and the teaching hospital will be in a way subsumed within the calculations of this differential pricing. And so we will no longer have these metro city and the teaching hospital incentive. However, the problem with this previous set of incentive structure was that all of the incentive was primarily only for certification level, whereas there is no specific emphasis on the processes after the certification has been obtained and the outcome of patients who are being treated in those hospitals that are certified or not certified. So as a result, what we want to move forward towards is a set of incentivization system where 50% of the total incentive amount is calculated based on the level of certification that you have. So the same principles apply, but they add up to 50% of the total incentive. And the remaining 50% is determined based on certain outcome indicators. And these are outcome-based incentives. So what are the outcomes of care that has been delivered there? So what it means is that the most fundamental question is that how do you measure or how do you define these outcomes based on which the incentives are to be estimated? So we wanted to be very explicit in terms of the choice of the outcome, the indicators, and we developed three broad criteria for including a particular indicator to make this decision. The first is that we wanted to make sure that whatever indicator that we choose, it should be such that it aligns with the broader principles and philosophy of universal health coverage and health systems performance measurement. Secondly, we want to also make sure that whatever data that gets collected, it is easy to collect that data. It is not such that imposes very significant constraints. It is not something that imposes very significant constraints on us to collect that data. And the third and another important feature is that it should be such that is internally valid. That means it enables us to reflect on a particular domain, and B, it is not very easy for providers or the people who are collecting that information to make any kind of arbitrary reporting errors or make any judgment calls on that data, or maybe game the particular information that is being provided. So those were the three broad criteria that we chose. Now, based on these three criteria, we identified which indicators we want to choose. So if you look at the overall universal health coverage approach, it basically lays emphasis on three ultimate objectives. The ultimate objective is to have better health outcomes, but this health outcomes is contingent upon care that is provided that does not impose any financial hardship, which means that there is high degree of financial risk protection. And also this care is responsive to the needs of the people, patient-centered care hai. So which means quality enable hoti hai, quality of care is good, and dignity of the patient is maintained, etc. So in तीन domains को identify करते हुए हमने indicators identify किए, and these indicators include, under the responsive patient-centered care, हमने दो indicators identify किए. One is beneficiary satisfaction, and the second is confirmed grievances. For financial risk protection, we have shortlisted an indicator which is out-of-pocket expenditure, and for the health outcomes, we have chosen two indicators to reflect on that. One is readmission rate, and the other is improvement in the functional quality of life of the patient before and after the treatment. So this is what are the indicators. So these are the final set of 5 indicators that we've chosen, which ultimately are going to be used in a composite manner in order to generate the remaining 50% of the total incentive amount. There were other additional indicators also that were considered, debated, but finally they were not considered appropriate to be included. These include, for example, hospital-acquired infection rate, which is a very established indicator to measure the quality of care. We do recognize that, but the problem in this indicator was that it is completely dependent on the reporting by the hospitals. And we know that if the incentive structure is determined based on this, then there will virtually be no reporting of any hospital-acquired infection. So as a result, we have dropped this from inclusion. However, it continues to be used as part of our quality checklist and as part of the efforts that are being done by the quality cells to engage with the hospitals and bring down these hospital-acquired infections. Secondly, another important indicator that was widely discussed was mortality, which is again very well established. But then the problem with this is that, one, the patients in different hospitals could be of different nature. One type of hospital is treating much more of those patients that are likely to have either oncology related disease conditions or let's say cardiac disease conditions, where relatively the rate of mortality is higher. So in a way, it would be disincentivizing those hospitals. Secondly, mortality is determined by a range of other confounders as well. And it is very difficult to control for all those confounders given the data that is available with us. And the third problem is that keeping this indicator into our incentive structure policy perhaps would create perverse incentives whereby the hospitals might be more incentivized or nudged to pick up selectively those cases that are relatively less severe that are milder in nature, जहां पर की risk of mortality बहुत ज्यादा ना हो. तो इन reasons की वजह से हमने ये दूसरा indicator भी drop कर दिया. Third indicator, which was again a potential choice, was length of stay, because we know that it is encouraged कि patient को as early as possible discharge किया जाए, so that वो जल्दी से जल्दी ambulatory हो, and we know that the outcomes are better if you have early ambulation. But the problem with this is then that the hospitals may have a pressure of discharging the patients early, even if there is a need for care a little longer. So as a result, these three indicators, while they were considered, discussed, and widely debated, these were not considered to be included for developing the incentive structure. However, it needs to be emphasized that these are very well established indicators to overall measure the quality of care being delivered, and as a result they remain within the overall framework that we continue to use, but not for the purpose of incentivization. There's an overarching indicator which is conditional for any hospital to receive any sort of incentive, and that is that there should be no fraud against the hospital. So if there is a fraud, then the hospital automatically will not be considered for any kind of an incentive, whether it is certification based or outcome based. तो अब मैं जो next कुछ slides में दिखाऊंगा वो ये बताऊंगा that हम इन indicators को collect करने के का data collect करने के लिए कैसे क्या approach हमने follow करी है. Now, in order to do that, the first indicator, as I mentioned, was beneficiary satisfaction rate. इसके लिए हम जो existing mechanism है, वो existing mechanism ये है कि call center से every patient receives a call on the second day of the discharge. And उस interview के अंदर already they ask that how satisfied is the beneficiary. तो उसी question को थोड़ा सा improve करके on a kind of a visual analog scale, जिसमें patient को कहा जाएगा कि rating करे on a scale of 0 to 1, that how satisfied is he with the type of care that is provided. तो उसको हम ये information collect करेंगे. और इसकी जो हमने rating scale बनाई है, वो हमने थोड़ा on the higher side बनाई है, because we recognize that in different surveys of patient satisfaction, beneficiary satisfaction, generally speaking, majority of the people say that they are satisfied. So as a result, we expect that there are large proportion of people who will report that they are satisfied, or they will report a satisfaction rate that is upward of 0.5, 0.6, 0.7. So इसलिए हमने इसको existing satisfaction surveys के data को देखते हुए हमने इसकी ये जो कट ऑफ लेवल्स डिसाइड किए हैं और ये मार्किंग पैटर्न इसका डिसाइड किया है. The second indicator that we had chosen was readmission rate. This readmission rate is going to be computed for an admission that takes place for the same disease condition within 1 month of the previous discharge. और इसके अंदर we do recognize कि कुछ ऐसी conditions हैं जिनमें कि ये एक तरह से applicable नहीं है. For example, dialysis, for example, other daycare packages like chemotherapy या other daycare packages. तो ऐसे packages की जो monitoring quality की होगी या जो incentives के लिए जो indicators compute होंगे, उनमें इस particular indicator को exclude कर दिया जाएगा. And जो remaining indicators हैं, उन्हीं के basis पर ही उसका summary score compute होगा. And इसके अंदर जो हमने ये cutoffs बनाए हैं, they are based on a review of standard literature, which says कि how much of hospital readmission rate for different disease conditions is kind of acceptable. The third indicator जो हमारा है, वो है out of pocket expenditure. Our policy is strictly against any kind of out of pocket expenditure that may be charged to the patient on account of any drug, diagnostic, consumable, etc. that the patient requires for the treatment. तो इसके लिए again एक mechanism already available है, which is an interview by the call center on the second day of discharge. इसमें ये सवाल भी पूछा जाता है कि क्या आपका कोई खर्चा हुआ हॉस्पिटल में अपनी जेब से, और वो खर्चा क्या दवाई के ऊपर या किसी टेस्ट के ऊपर या इन चीजों पर हुआ. तो अगर if there is any of the such direct medical expenditure, we are not saying travel pay, we are not saying on anything else, so we are only saying on these aspects. अगर हुआ तो then we do not give any mark at all, whereas if there is no expenditure then we give 5 marks. So here again there was wide discussion that in our existing policy also we say that if there is an out of pocket expenditure reported, so then this becomes like a grievance, and if it is the case, then this has to be resolved, और इसका जो resolution होता है वो होता है या तो hospital से अगर prove हो जाता है कि expenditure हुआ है तो then he has to return that money, और अगर वो multiple times हो तो then say there could be some punitive action that could also be taken. तो the argument was कि अगर punitive action है तो फिर हम ये इसको include ही क्यों कर रहे हैं. The point is that in that particular case the hospital refunds only the expenditure that was charged by the patient to by the hospital to the patient. But in this particular case, if we give a 0 mark, then whatever incentive amount is reduced or whatever lesser score that the hospital receives is applicable not just to this particular package, but gets applied to all packages that are being delivered in that hospital. So in a way, it reinforces our scheme's intent to ensure that there is no out-of-pocket expenditure and make conditions even more favorable for hospitals that do not charge anything to the patients. The fourth indicator is confirmed grievance. Again, इसमें हमारा CGRMS portal exist करता है, Grievance Redressal Management System portal, and our criteria is that there should be no confirmed grievance. And if there is a confirmed grievance, then you don't get any mark in this particular indicator versus you get full marks if there is no confirmed grievance. So till this point, first से लेके fourth indicator तक, we have existing mechanisms either through call center or through CGRMS portal or through our TMS system that enable us to compute the relevant indicators. जो last indicator है, which is to measure the functional improvement in quality of life, इसके लिए this is the only indicator जहां हम additional data collection करेंगे. और उसको करने का जो तरीका है, that is very simplified. Simplified in the sense that we are proposing to use the EQ5D 5L tool. ये जो टूल है इसके अंदर बेसिकली किसी भी पेशेंट से 5 डोमेन्स में सवाल किए जाते हैं कि आपको चलने फिरने में कोई दिक्कत तो नहीं है, मोबिलिटी कैसी है, हाउ डू यू हैव एनी प्रॉब्लम रिलेटेड टू सेल्फ केयर, यानी कि जैसे अपने आप को नहाना धोना कपड़े पहनना, यूजुअल एक्टिविटीज में आपको जो घर के काम, कोई फैमिली के साथ कहीं जाना आना, उसमें कोई प्रॉब्लम है कि नहीं, डू यू हैव एनी पेन डिस्कम्फर्ट और एंजाइटी. Or in each of these domain, we try to rank order the level of difficulty in terms of either no problem at all, slight, moderate, or severe problems, or a problem that is so severe that the person is unable to perform a particular function. तो जब हम ये सवाल करते हैं तो हर patient के लिए वो in each of these domains he simply puts a response to each of these, based on which you basically generate a profile of the health state. So for example, यहाँ पर first domain में 1 है, second domain में second level को pick किया हुआ है, third domain में third को किया हुआ है, fourth को और fifth को. तो इसकी जो health state बनी वो बनी 1, 2, 3, 4, 5, because each domain में इसका ये different levels थे. और हमारे पास already एक value set available है जो कि हमारे को हर different potential combination of this से जो health state determine होती है उसकी एक index value of quality of life we are able to get, जिसको हम यूटिलिटी स्कोर कहते हैं. तो ये जो वैल्यू सेट है इसको हम आईटी से बैकग्राउंड में इंटीग्रेट कर देंगे थ्रू द एपीआई. तो जो हमें इंफॉर्मेशन कलेक्ट करनी होगी वो व्हिच वी विल ओनली हैव टू कलेक्ट दिस इंफॉर्मेशन, रेस्ट ऑल एक्टिविटी विल बी परफॉर्म्ड डायरेक्टली ऑटोमेटिकली बाय द सिस्टम. तो देयर विल बी अ हेल्थ स्टेट दैट विल बी जनरेटेड एंड अ क्वालिटी ऑफ लाइफ दैट विल बी ऑब्टेन्ड. एंड ये जो क्वालिटी ऑफ लाइफ की मेजरमेंट है इसको हम 2 टाइम पॉइंट्स पे करने का प्रपोज कर रहे हैं. 1 बाय द पीमैम आरोग्य मित्र एट द टाइम ऑफ एडमिशन व्हेन ही रेजेस द प्री-ऑथ, एंड सेकंड व्हेन द कॉल सेंटर इंटरव्यू गोज ऑन 15th डे ऑफ द डिस्चार्ज. तो जब 2 टाइम पे हमारे पास क्वालिटी ऑफ लाइफ की वैल्यूज आएंगी तो व्हाट वी विल डिटरमिन इज दैट व्हाट हैज बीन द इंप्रूवमेंट इन द क्वालिटी ऑफ लाइफ, एंड देन व्हाटएवर इज द इंप्रूवमेंट इन द क्वालिटी ऑफ लाइफ, उसके बेसिस पे हम रादर देन उसकी एब्सोल्यूट इंप्रूवमेंट को देखने के लिए हम रिलेटिव इंप्रूवमेंट के अकॉर्डिंगली हम उसकी परसेंटाइल बेस्ड स्कोर्स कंप्यूट करेंगे, जिसमें कि which means that it will be like a comparison across all patients treated in all hospitals and उनके बेसिस पे ये कट ऑफ्स डिटरमिन होंगे. So this is like a kind of relative competition between hospitals to ensure that there is a better and better quality of life, rather than कि कोई absolute competition या comparison within a given hospital or a patient. So these are the ways in which each of these 5 different indicators, the data will be collected, the analysis will be done, and certain marks will be generated. So just to summarize the last the EQ5D at the time of the pre-authorization, when the PMAM registers the patient, there is this tool gets administered, एक प्रोफाइल जनरेट होगी, IT सिस्टम से ऑटोमेटिकली उसको एक हेल्थ स्टेट मिल जाएगी. फिर जब फॉलोअप कॉल 15th डे ऑफ डिस्चार्ज पे जाएगी तो अगेन एक उसकी हेल्थ प्रोफाइल सीक करी जाएगी पेशेंट की इंटरव्यू के माध्यम से, और उसको ऑटोमेटिकली एक क्वालिटी ऑफ लाइफ का स्कोर मिलेगा. इन दोनों वैल्यूज में डिफरेंस निकाल के उसके बेसिस पे परसेंटेज चेंज और इम्प्रूवमेंट कंप्यूट किया जाएगा. We also recognize that इसके अंदर there is a lot of subjectivity, even PMAMs या कॉल सेंटर एम्प्लॉइज की स्किल्स और एबिलिटी के ऊपर काफी चीजें डिपेंडेंट हो जाएंगी. But we also want to create an opportunity whereby the patients can themselves directly report their outcomes on each of these 5 different domains as an app that can be provided to them. So we want to place this power in the hands of the patients to generate, auto-generate this data, जिससे कि hospitals का incentive amount compute होगा. So this is a work in progress whereby this app will be developed, and at least those beneficiaries who are literate and who have a smartphone that enables the downloading of an app, so they will be able to self-report. However, the parallel system of call center and PMAM enabled data collection would still continue to go on. So going forward, the plan is to have a pilot conducted in about 6 states, and then as part of that there will be trainings that would be given to the Arogya Mitras, the call center people, and an orientation of the state health agencies. The necessary IT integrations for the generating the indicators would be undertaken, and then about 3 months time will be spent to collect some baseline preliminary data to see that how the system is likely to operate, how the data would be collected, analyzed, and indicators computed, and then an incentive amount calculated. This entire approach of value-based incentives is not just to determine the incentive structures or the money that the hospitals receive, but it is also it is also proposed to be used to create a public dashboard for hospital performance assessment, whereby as within each of these domains of the indicators that we spelled out, there will be a performance of the hospital that will be listed, and there would be a composite score also that will be given to the hospital, and this can in the later time also be drilled down not just to the hospital but within individual specialties within the hospital. So it is like if you have to travel somewhere and you want to search for a hotel, then you go to the websites and you try and see that which hotel is better, which hotel is good. So similarly, we provide this kind of hospital rating also on a platform which is accessible to the patients and the beneficiaries. So it in a way creates a demand side push for hospitals that perform better in terms of different aspects. So finally, we conclude the second chapter of the consultation paper by inviting comments from stakeholders. And broadly speaking, the comments are in terms of 5 different aspects. Firstly, we invite comments to on the 5 proposed indicators that we have proposed. Would you like to have what is your suggestion in terms of the comprehensiveness of these indicators? And also on the approach that we have outlined for the data collection for each of these different indicators, and the computation methodology and marking system. And we also invite comments from the stakeholders to suggest that do they think that the indicators are sufficient enough to capture the kind of value within value-based care, and if not, and if they have suggestions for inclusion of more indicators, then those may be suggested in terms of their name. Why do you feel that it's relevant? What kind of data is required in order to be collected for generating this indicator, and then finally its computation methodology. So these are the different aspects that we seek your opinion on. And we have given a timeline of the 21st of July for different stakeholders to submit their responses. The responses could be in terms of your suggestions on how to improvise this, your agreement or disagreement with either of these, and then how do you think it should be taken forward. We have also created a Google form link on the website for those who have some institutional and organizational policy constraints in terms of uploading or using the Google form. We have also provided an Excel spreadsheet that has been prepared in a way that each stakeholder should use the same template to respond to, and those could be submitted to an email that has also been specified. I'll request my colleagues who are here on the call to post both the Google spreadsheet and the email address where we expect the stakeholders to submit their responses. So I'll stop here, and we'll now open up for questions. We'll encourage all of you to please post your queries and comments and feedback in the Q&A or the chat box. We'll gradually take each one of these, and we'll then see that if we have time, then we'll open up for a general discussion or Q&A. But till then, we'll try to respond based on the Q&A that we have received. So I'll start with the questions that have been posted in the Q&A section, and once I'm done with this, then I'll move to the chat box. So I'll request if you can keep putting in your questions there in the chat box. So the first is that I've updated the HEM portal 15 days ago, but till now updated by SNA Jharkhand. Please help me. So I think that this is something that is something where you need to engage with the state health agency at Jharkhand. I do understand that there are certain constraints of the HEM portal, sorry, I was looking at the Google chat. So I know that there are certain constraints of the HEM portal and the state health agency has also imposed certain requirements in terms of uploading certain videos also of the providers who have been listed as specialists in your hospital. So please ensure that you have provided all the necessary information. The second question is that is posted by, please share the link for the response document to comments on pricing. So I think that my colleague Dr. Priyanka has already given that in the chat box. This link is also available on the website, PMJAY website. The third is that length of stay is not considered in incentivizing the hospitals for concern that hospitals may drive out critically ill patients, but using enhanced monitoring technology during surgery proper. Can we have an audit? Yeah, so that's essentially the reason why we have also decided against inclusion of the length of stay as an indicator. So this is exactly the same reason. So we, however, continue to be a little bit prescriptive in terms of what we define as the appropriate average length of stay in our standard treatment guidelines. But for the purpose of computing the incentives, we would not include this. Another aspect of value-based award for providers can be whether the patients have reduced cost of health maintenance post-surgery. So, Dr. Sudha, we can maybe follow the same pattern and we can pick up questions alternatively to cover up everything in time. So I am at the Q&A session in the Q&A chat box, and I've finished the first, second, third, and I'm on the fourth comment. So I'll read it out, and by the time you can maybe. Okay, so this question is about, so as I mentioned that we do not have mechanisms to look at the whether it has reduced the cost of health maintenance post surgery. So that provision is not there because we don't have that provision of tracking the patient subsequent to the discharge thereafter. But what we do have, but what we do recognize is that our readmission rate indicator, to an extent, it is also indicative of whether we've been able to reduce the cost of care following a given procedure. So if there are less readmissions, that means there are less needs for further hospitalization, and that automatically, in a way, translates to that.
If we go to the next question, I think, is this independent of the package pricing framework? Yes, because the HPP pricing framework that is already released and discussed is completely different. What we are looking here is, to some extent, how do we make sure that the packages are comprehensive and that also adds value. I think in one of the slides that he had covered, Dr. Shankar, in terms of the HEFTA, there is a linkages to the policy package pricing framework, but the incentives as such is above the package price that is being determined. So in that sense, what we are trying to do here is, for the amount of the package price that we are paying, what is the kind of the care that the beneficiary is receiving. Your understanding is correct that here we are trying to make sure that the patient hospital or the patient clinician interaction is also improvised, so that the outcomes for the beneficiary is enhanced than what it would be just by paying. So here we don't want to just be a payer. So beyond payer, we are trying to insist on certain level of quality, which is very important, because our pricing is something that is one of our fundamental responsibilities. But along with that, ensuring good quality care is also very important.
Next question is on the HFR registry in our hospital. When will it be approved? I think this is something that is linked with the ABDM. So I'll skip this in the interest of time, but I'll move to the next one, which is, or Dr. Sudha,
they can provide the name of the hospital. We can get it fast tracked if there is any barriers or anything limiting. So you can just type in the chat box your hospital that is pending approval. We'll follow that up. Yeah. So while providers are willing to provide continuum of care, what are the plans to change the patient behavior to continue treatment? Yes, definitely. I think it's a continuum of care is a bigger concept, and we will have to ensure that the roles and responsibility of each level of provider needs to be enhanced and facilitated. So here, definitely patient behavior is also something important. A good follow-up post-discharge and good counseling post-discharge, or even pre-treatment when he is identified at a low level. I think there it is very important that counseling would help change the patient's behavior also, and ensure that he takes his compliance to the treatment and the directions given during the thing. We can see how to enhance it. But as we say that, it is still a concept that we need to work a lot more, because we are only handling one vertical, that is more on the hospitalization side, and building bridges with the health and wellness center, with the follow-up, even decentralized follow-up at public hospitals or private hospital. Those are things we need to bring those linkages, and which I am sure that NHA has taken it as a mandate to work with the health and wellness centers and other stakeholders. So we hope to ensure that this concept, maybe the next consultation paper would be on continuum of care once it is approved by our board in terms of NHA to take that role.
Sure. Next is around there's a query. So you're asking that where have the been the reply of the NHA been posted for the previous consultation paper. So it's available at the same place where the consultation paper was hosted. So under the publications heading, you can go and see the place where the consultation paper was uploaded. And at that point itself, there is an additional hyperlink for accessing the NHA feedback. I'll request if Dr. Priyanka can quickly find it out and post it in the chat box itself here, so that'll be easier for people to go back and see.
Yeah. with this suggestion in terms of the indicators and to have an individual hospital baseline and the improvement as something that you consider, I think for some of the indicators we have like 0 or 5, like, you know, the improvement levels are quite drastic. So I'm not sure we are looking at individual hospital, but overall, in terms of looking at those points, we are looking at all the indicators comprehensively. So not just one indicator, and somebody improves in one indicator but has a very bad, you know, score in the other indicators. Here we are looking at a comprehensive score and an overall percentile we are looking at, and ensuring that, you know, that is well captured. So none of the indicators we are looking at individually, but definitely a comprehensive score, and identify where the most improvement needed. Definitely that is there. Maybe that will come as a feedback as we do the pilots. Also, we can relook at this, you know, option. But definitely we want to score the hospital, because a rating, when we say a hospital rating, we cannot give a rating on one indicator, whereas other 2-3 indicators are very bad, right? So even in your own experience, as any service that you rate as good, bad, you know, or give star rating, you will take all factors into consideration and give a final rating. So here, similar thing we are also trying to do, multiple indicators, but overall rating of hospital is something we need to arrive at using those indicators.
Right. And just to say that it is basically a beginning. So we have to make a beginning at some point of time, and we have to make sure that we choose certain indicators that are at least easy to collect, not possible to be gamed, etc. So with that kind of a philosophy, we are going ahead. So the next question is also quite similar, on a similar note, that satisfaction surveys are subjective, and there is a suggestion that there should be some kind of weightage, less weight to certain indicators, more weight to other indicators. So another issue that we wanted to highlight was that we wanted to make the entire computation process and all relatively more simpler, so that it is easier for all stakeholders to even understand that as well. So if we make it so complex that there are weightages also that are given within different indicators, then sometimes it is difficult to comprehend also. And also sometimes the level of acceptability then drops on that particular thing. But this is something that is something that we would be willing to be open to making any kind of amendments in future. We are the first 3 months that we are going to roll out this pilot would be mainly to learn and to try and establish the kind of baseline, and that would help us to also look at some of the general trends. Those trends may also inform us in some way to even perhaps fine tune some of the cutoffs that we have set, or maybe defining some of the weightages that we perform to provide to each of these indicators. But at this stage, we thought we'll keep it relatively more simpler. In some cases, as you might have also seen when I presented, we have chosen a percentile based method which means that there is a kind of a relative competition between hospitals than an absolute benchmark, which is a percentage of within the same hospital.
I think readmission rate may not be the only indicator that might be representative. So we are not saying that that is one indicator that will is representative of the whole quality of care, but it is one of the indicators, right? Again, readmission can happen due to various reasons. So we will be looking at the analysis and through our TMS, whether it is for the same package, whether it is for a complication of the same package, or whether it is happening after a long time, whether, you know, the impact of the same treatment may not have any bearing on that recurrence. Like if it is a recurrence of some, you know, post a particular length of time, then it may not come. So for us, a 30-day readmission is what we are looking at. So we will be using it as a part of the whole mix of indicators, and not just use it as any one criteria to, you know, rate a hospital on.
Right. So I'll take the next two questions together only, Dr. So one is on simply out-of-pocket expenditure. Is the suggestion is that why? I mean, so the question is that if something is not covered, then it needs to be so. Then why not let them report it? So we're not saying that we are stopping them for reporting it. We actually do encourage, or as a policy, we say that we have zero tolerance to any out-of-pocket expenditure, because our package is supposed to cover the cost of all diagnostics and medicines that are being used. And the fact that an empaneled provider contracts to be part of the overall chain, it is an implicit consent to adhere to those package rates. We have tried making a lot of refinements to these package rates to ensure that there is complete coverage of all costs that a hospital incurs for provision of care. And so any then subsequent expenditure that is now being reported by a patient is something that would not be appropriate. And the second question that you have, that HRQL, yes, the question is going to be digitally integrated. It is not something that the person who is collecting this information has to actually choose that what is the index value. So this will be done directly. Just the initial part has to be done by the person who administers the questionnaire.
Okay, the next question is on the quality of materials, consumables, implants, pharma for delivery of care. Definitely, we are trying to work on that. I think in the current package, we have mentioned that the implants and has to be FDA or CE or DGCI approved to the at least to the high-end implants and consumables. And we are also working on the committee to form. And we have opened up the request for representation to the committee to identify certain specification and standards for high-cost implants for both orthopedics and cardiology. I think is that advertisement out, Shankar?
I think that advertisement is going to go out in about another 1 or 2 days. So we are getting nominations from experts who would like to be part of that consultation, whereby we set these standards and specifications.
Yeah, so we identified that though there are certain standards already available, we will follow those standards. But for some of the implants where we don't have some standards, at least for the sake of PMJAY scheme, this committee will give some guidance on the standard so that will be used during the processing of the claims and review of the implants used in the patients. So,
right. Is DRG payment system a precursor to using coding system for payment processing? I think the DRG based payment system, yes, this is something that a pilot is ongoing, and we are exploring the possibility of using different DRG groupers for the purpose of coding. So yes, the coding of the disease condition will take place before the payment is actually determined, when the system kind of materializes and that this reform is introduced. So given the clinical information, given the disease category, severity, etc., a code to that would be assigned first, and that code will determine the level of payment that the hospital receives.
I think the next is on what's the next plan? How do we track long-term outcomes? So our next plan is to, roll out some pilots in 5 to 6 states and ensure that, some feedback on the operational feasibility of this whole process, and both in the IT level at our end, how this integration and the data sharing can be automated so that there is minimal, as much as possible, limited individual interventions to identify some of the scores. So that is our plan. And to track long-term outcomes, I think for that, we are looking forward to more of the ABDM integration, because we might lose out on a lot of patients because either post or discharge, we don't have any mechanism of tracking those outcomes. So long-term outcomes is currently not possible within our scheme construct. But we definitely hope that the continuum of care, there could be some kind of integration with the wellness center and the tracking that can happen through them for some of the conditions. The follow-up care packages that we have will give us some more outcomes of how many people actually took the follow-up care, and if they did not take, we can have some surveys or feedbacks from the patients or their attendants on what happened to them. So in that sense, at least mortality is something we can track. We have done to that extent some experiences where we have done verbal autopsies and identified the reasons whether the bad outcome was just post-surgery or was it something due to other reasons. So in that sense, some things can be tracked, but I think the bigger picture we will get only when we have a good e-linkages through the ABDM system, and the patient tracking through the ABA ID can be done as to where all the patient had and what has been his current status. So we have to wait for that.
Next question is around how do we do use this framework for hemodialysis and other services, daycare services, because this is mainly for inpatient care. So as I did mention that one of the indicator which is around readmission rate is something that would not be applicable to daycare centers, chemotherapy centers or hemodialysis centers. However, the remaining indicators such as any grievance, any out-of-pocket expenditure, the improvement in the quality of life, etc. Those indicators continue to be measured even in those centers, and as a result, there is going to be a composite value that would be determined based on the remaining indicators. So it's just that one indicator goes off, and that's another reason why the weightage between the different indicators was not considered a more appropriate idea.
So continuum of care is listed as one facet of value-based care. So standalone diagnostics to be covered as part of the continuum of care. I think we do already have standalone diagnostics, at least for some of the, there is already for at least COVID, there was the standalone diagnostics were empaneled, and in going further, we would be looking at how do we use these standalone diagnostics now with the ERUP coming in. I think that is some initiative that wherein we are having the diagnostic packages part covered directly through the ERUP voucher system. So that again, we will be looking at to what extent we will be involving these standalone diagnostics and see some of the diagnostic packages which are already there. How can we operationalize through the diagnostic centers? That also is important to reduce the out-of-pocket expenditure.
And since Dr. Sudha has mentioned about ERUP, I think I am a bit tempted to inform that this is a pilot that has already been introduced in Chandigarh, and labs have been registered for this the application of this ERUP voucher. So a patient who comes to a hospital and has to get certain diagnostics that may not be available within the hospital, they can these diagnostics can be done in either of these different labs, and the voucher is redeemed. Payment goes to the lab directly, and automatically that amount is deducted from the payment of the hospital when the hospital is paid later on at the time of claim dispersal. And this is something that we want to expand to other states also, and maybe create some opportunities whereby diagnostics for other conditions where diagnostic cost is really very high, like oncology for that matter, also becomes part of within the ambit of so even pre-hospitalization diagnostics for oncology care, if that can also be covered by ERUP, is something that we are working on. So next question is on how to avoid underscoring of quality of life at admission. This is a very important point, and we do recognize that there is, there's definitely a scope of gaming this particular indicator to begin with. What we hope to do is that the pilot will help us to determine certain baselines. Secondly, we will have some data that triangulation that we can also do, and some kind of validation checks that we can put in. For example, we have also integrated the ICD coding along with within our TMS system. So now we have information also of the multiple diagnosis, the kind of severity also, etc. So some degree of we can have some kind of validation or some kind of correlation between different indicators that are being fed by the same hospital. And thirdly, we will have some system of validation whereby we can, for similar set of patients across different hospitals, if there is a particular hospital who's consistently reporting poorer quality of life at the admission, we'll have that kind of system of building in some kind of checks for this incentive.
So integrate the hospital rating with Google Maps so that all citizens are aware, and same goes for certification. I think we are coming up with Map My India kind of concept wherein all our hospitals are also mapped, so that through a mobile app it's easier to identify which is the closest hospital, and that can be seen in the Google Map. I think what we could maybe in future we can explore this option and see with the rating, right? So with kind of stars or something in addition to the location of the hospital, there could be some flags associated when zoom in and you want to know more about that hospital. I think like how you are, the hotel maps, they just give you those dots, but then when you zoom in, you can see the rate, you can see the, the kind of some rating, something like that. It's a good idea. We will explore that.
Next is there any plan to evaluate tariff based on cost of treatment? So we have now have had sufficient experience, and we've kind of consolidated a database of healthcare costs that we've been able to build on a large costing study, and that those estimates of costs that have been collected from a very representative set of hospitals across 14 states have been used for the recent price revisions also. So and that database is continuously being built further. More data is getting collected and more information is being generated, so that we have very detailed granular information on the cost of different services, which helps us to determine these prices and tariffs.
Will there be periodic audit from PMJAY to collect data on chosen indicators? Yes, at least for the call center grievance, already the audits are happening and we are reviewing that, so that we will expand that. And with the clinical audits, again, definitely yes, because whenever there is readmission or those kind of things, we will be meeting repeatedly in a particular hospital. So these are some of the triggers that we can integrate within our NAFU system also, so that that can give us the flags for such kind of from a repeated hospital also we can look at. So these are things that definitely audit of these key indicators will have to be done, but we will be looking at better, smarter way of doing it than just a random sampling, and we would be looking at trends from various aspects and then identify the hospitals or identify the cases where we need to go in depth about such cases.
There's a question on value-based purchasing and procurement in this framework. So this particular aspect was dealt with in quite significant detail in our previous consultation paper on provider payment and pricing, where we talked about this this framework of using HTA evidence on cost effectiveness and other parameters to inform a price negotiation decisions that could be undertaken subsequently. So this is something that we have informed in great detail in the previous paper, and a lot of queries that came in on this particular thing have also been responded to in our reply document that has been posted up on the website. So I'll encourage you to please have a look at that.
So can we look at qualitative outcomes beyond EQ5DL, whether it's functional outcomes like urinary incontinence or sexual functionality, certain procedures? So this is something to start with, we want to be more generic, and we do realize that certain packages we need to make sure that, post a procedure, actually the condition may deteriorate also, or just because of the natural progression of the disease. So we have brainstormed on that. How do we have some package specific outcome data beyond the Euroqual? So that is the next phase of expanding the scope of these indicators. But to start with, we want to be more generic, but we will be going package specific, at least in some of the conditions where the outcomes are quite different pre and post the treatment, mainly because of the inherent nature of the disease.
The next question is related to a medication database that might be centrally driven by PMJAY, and whether there is the quality value for each of the medicine that might be available. So as I mentioned, that the attempt is to appraise each new drug or device that may be recommended for inclusion in the health benefit package on grounds of not just the incremental value in terms of the quality gained, but also in terms of the incremental cost. And then based on what is felt to be or recommended to be cost effective given the standards and the thresholds in India, make the decisions on recommendation or not to recommend. So that eventually will determine that what gets in and what gets out of the package. However, beyond that, to say that in each of the package, since it's a bundled package and the bundled package has a bundled price, we do not necessarily disaggregate and break that down into individual services like which medicines to give and which diagnostics to offer, etc. There are certain mandatory documentations in terms of diagnostics, but medications, there is no prescriptive this thing right now. However, we do want to standardize the process of reporting the use of different medicines. And this is something that we are trying to pilot as part of our DRG pilot, where we are trying to incorporate the SNOMED CT codes for medicines into our transaction management systems, so that hospitals reporting on costs in terms of medicines are able to report on standardized nomenclature rather than any other things.
And the next one is a little tough, value-based framework, which is patient-centric satisfaction. And yes, definitely bias is something that we are worried of on patients' behalf, and calls for scope for validation from hospitals, enabling a cross-validation form of measuring patient satisfaction. This question is in purview of cases like neonatal deaths due to natural circumstances, leaving out scope for quality of care provided. These circumstances can lead patients to give a biased response. I think one thing we are also looking at here is mortality. We have excluded as an indicator. So we will be identifying that as something that needs a special kind of assessment and consideration. So we need to relook at wherein the deaths cases, how the satisfaction. I think there's a good thing to understand more during the pilot, whether the kind of satisfaction differs in patients who are discharged versus patients who have a bad outcome. So that definitely we will have, and we need to make some adjustment for that. But many a time it also happens that the patients are also aware that all the required treatment was provided, treatment was good, but still, the patient, they could not save. So there would be some level of, understanding, but not in all cases. So this is something we will explore deeper on how these differences in rating happens during with different outcomes for the patients. I think that we need to make a Dr. Shankar. We can consider that in our pilot and see if there are any differences. And we can make some adjustment factors to factor in that when the bad outcomes, to what extent that influences the rating.
True. The next question is, what is meant by a confirmed grievance? So basically, a grievance that is reported by the patient through either of the different channels, whether it is CGRMS portal or some other mechanism, it is always investigated by standard processes. So there is DGNO, which is a district grievance nodal officer, then there is a state level, and then there is a national level, a grievance redressal committee. So there is this, there are these escalation processes, metrics also. So once a grievance is received, it is investigated, and if found true, that is something that we label as a confirmed grievance. And then there is some kind of an action to correct that is taken.
Okay, so the next one is regarding the standalone dialysis centers empanelment. So state do have certain different policies compared to the national. So NHA has released the empanelment guidelines for standalone dialysis center, which is already in practice. So from our side, we won't be able to comment on it. But if it is a state-specific issue, then flexibility is also there for the state, whether they want to engage with standalone diagnostic dialysis centers, or they want to have it in a hospital setting. So I think that will completely be a state's decision. But at the NHA level, the standalone dialysis center guidelines are there, and it's permitted to empanel them if the states wishes to.
In terms of out-of-pocket expenditure, there is a suggestion to have a weightage based on the actual amount paid compared to the total amount of package, and also proportion of patients who are paying out of pocket to the total benefiting from this should be considered. And this is a very interesting suggestion, and this is something that we have considered and debated very strongly within our internal discussions. And basically what we concluded was that if we make any such kind of a choice of an arbitrary cutoff, that okay, we say 5% of the package amount, at least we say that you still get 4 marks as for the incentive calculation. then what it means is that we are kind of justifying the out-of-pocket expenditure that may be incurred up to, let's say, 5% of the package rate. Now that is something that contradicts the scheme's original principles and premise, which states that there should be no out-of-pocket expenditure. So it is in that line that we also had a very, back and forth positions on this particular thing, and we ultimately could only reconcile with this only criteria, that there should be no expenditure, because that is something that also fits into the overall scheme's principles.
So, and we also mentioned that OP, is it for the the components covered under the scheme or not? I think every grievance of OP is investigated and looked into to check whether the OP was part of the scheme package components or something that was unrelated to. I think that definitely will be something that we will be confirming it before considering that as a major issue. So the next one is, how do we know if the patient chose not to get readmitted? How will one know if the disease worsens and therefore improvement in health did not happen? So system to follow up with patient over a period of time and seek patient's feedback or specific period or till the end of life. So definitely readmission is something which is a standard way of how that readmission is measured. So we are going through the standardized process of how the readmission, but if a patient chose not to get readmitted, he will never reflect as readmitted, right? So we will not get the data at all into the readmission category. So, and if the disease worsens, we do know the kind of the progression of disease in most. So at least we know that readmission rate for some complex surgeries is expected to be so much. So in that sense, if we find a number of readmission for simple cases, and if it shows the reason for readmission is sepsis or something which is more preventable, so we need to relook at that condition. And here is where we have the clinical audit, which will definitely know exactly what happened in that patient's journey, right? So this will take some effort from our side and from the state side to ensure that wherever these readmission cases, like how we have mortality, all mortality cases needs to be audited. So in that sense, maybe we might have to bring in some kind of a clinical audit for readmission cases, because I'm sure this is not a big chunk. So it will be a small number. We will need to look at it from the clinical perspective and then say whether it was a preventable readmission or something which is not preventable. I think there is something we can explore this further and see how we can handle this.
The next is on DRG. Dr. Sudha, I think let's be a little bit more quicker, because okay, so let's try and wrap it up. So DRG system, we are trying to explore codes, and we'll try to we are going to go ahead with the same methodology. Details of this are in the other consultation paper. And somebody has asked about the location. It's at the under the PMJAY publication section, and then you have the link. Priyanka, please post a link in the chat box.
Again, this is a question of readmission that we have already answered. It's part of this incentive on package or total turnover. Incentive is on the package, not the total turnover. It's based on the package level incentive.
Important to consider if the hospital has to spend extra additional to package count for certain patients. Yeah, this is something that is beyond the scope of this present this thing. But our intent is always to continue to have an analysis of the kind of cost price differentials that our prices should ultimately reflect the actual costing structures within the hospital. And we try and make a very concerted effort during every package revision to make sure that package prices that do not reflect the actual cost incurred by the hospital, that is corrected.
Okay. I think the next one is outcome measured for disease. I think, should we stop reading the question and just start answering? I think then we can save some time. Okay, so definitely we have the standard treatment protocol. So we do know what is the standard treatment process and what would be beneficial. So at least in major conditions, we do know what is the first line, second line, what can be done. And definitely costs are more or less based on the kind of procedures that you do. So we would be following the standard protocol. So we won't want to jump. I think we don't want to jump to a bone marrow transplant without, checking out our other measures, right? So we are looking at a stepwise treatment process and based on the patient requirement and how we are doing. So here, I think it is the treatment protocols which can help instead of the decision making, but inclusion of certain procedures to better improve may be supported by HEFTA and HTA based on the so that we can include more treatment packages into the list.
So I think I've gone through all the comments so far in the Q&A. I think they all are similar and we have responded to all of them. Last is about neonatal outcomes. And basically it is just to say that we will, as we go along trying to roll out this pilot, we will also learn about the specificities of each individual condition. And perhaps we may take some course corrections in terms of the weighting and in terms of the actual the way in which we compute the final composite index. I think we're really running out of time. We have a full chat box to respond. So what we, if you agree, Dr. Sudha, we'll copy all these comments that are there in the chat box, and we will incorporate these in our the final response sheet to all the comments that we will receive later on also.
Yeah, I think if we look at it, anything very important, we will respond. Otherwise, we can just run through it in a minute.
Yeah, a lot of these readmissions related,
which we have already answered, then we don't have to look at. Length of stay can we have audited.
I think each one of them might require a discussion.
Yeah.
So we'll respond to each of these questions maybe as a thing.
I think there are lots of them, but thanks very much for all the interesting participation.
And we'll request you to please send us all the feedbacks as you would have recognized and realized that we will not leave any of your comments unanswered, and we will definitely consider all of these in the final summary of the responses that we will prepare, and we definitely take into consideration all the suggestions that that require a change in our strategy. So for example, there was a comment in the chat box to say that are the submissions invited, or are they eligible to submit responses in the Q3 also, which was based on our previous consultation paper where we talked about HEFTA. So the answer is yes, we have made that change, and that change was based on the responses that we received only. So as I said, please do give us responses. These responses will help us to make course corrections, and we'll adopt all those suggestions that we feel are relevant and that require a change in the approach that we are taking forward to. So thank you very much, and we look forward to your detailed feedbacks as part of either the Google link or you can send us on email at the address that we've already specified.
Thanks everyone.
Thank you.